Dear colleagues, since we are all, almost all of us, we are specialists on monitoring. For us, I think it is very important that in every country, the monitoring and reporting system works well, and that the EPID surveillance in this country is very well established, and we are all sure that the routine data that are collected and are analyzed, visualized, and the problems are being solved. And all the data, yes, we have to make sure that the data is of high quality. So we know very well that if our data is not accurate and are not quality, the analysis that is done after that will not present the actual situation in the country, and the problems that are supposed to be solved, they will not be effective in the best case. That is why the first step to conduct monitoring and reporting, the main thing is that we are sure that we are doing everything correctly, properly, that the data is of high quality, and then analysis of the data and all the further steps, of course, they will be very accurate and very good. And now today's session will be dedicated to evaluation of the quality of our data. The data quality, key components, and methodology. So during the session, we're going to discuss how to determine the different aspects of the data quality, identify different dimensions of data quality, or understand what factors that improve or spoil the data, understand how to conduct data quality assessment, and demonstrate how to mitigate data quality issues. Let's just think about, so we are here, we are people who are dealing with monitoring. So let's think about the cases that we had in the facility, and when the data were underestimated or overestimated, and we have to do something. So let's think for a couple of minutes, and then we will listen to every country to say what are the most serious problems at the beginning of monitoring, okay? Is the task clear? Yes? Okay. Let's imagine, or just recall the cases when you went to some facility. Without microphone, I cannot hear, sorry. So yes, it is on monitoring. Okay, wonderful. In every country, there are people who know very well what the data quality means. What did you do when you noticed over-reporting or under-reporting, or how did you realize that this was over or under-reporting? How did you solve this problem? You can answer yes. Okay, so as an example, in one of the cities, not the region, but a city, they had a policy somehow. They wanted to hide the morbidity. It was not, they didn't want it to go beyond the average of the district or the region. So that is why the colleagues, they treated the patients, but they did not register them in the system. How it was revealed? We revealed it according to the analysis of drug application, drug administration. We realized that it is not comply. There is some discrepancy with the number of patients. So we went to the site, we checked all the papers, we talked to the hospital administration, went to the healthcare department. So we realized we uh, explained to them that in the country we have this problem of underestimation of TB cases, and we explained that it's very good when we estimate correctly and reveal all the cases, etc. So this is how we try to break the stereotypes, that those post-Soviet stereotypes, that it is very bad that we have many people sick. Okay, thank you. Very good example, and I would like to underline here that such mistakes can be encountered everywhere in Georgia, in other countries. So people who are dealing with this may have some surprises. Sometimes it is even difficult to imagine that you can find anything like that. But the best thing that I liked about your case is that you went to the site. Without that, you would never understand whether the data is correct or not. And only through the chemistry network, we realized that they give out more drugs than the patients registered. So such things can be revealed only on site, and through electronic system, you can never get that information. Okay, Anush, please. When we go to the site during monitoring, we check all the registration logs. First of all, we compare lab data with the revealed cases and suspected cases, and sometimes we have this plus in the lab, so an expert, etc. So this is a confirmed case. And this case is not registered, and 𝗵𝗿𝗄 cannot be seen anywhere. So we've had cases like that. And what was the explanation? Why? Did not manage, so not enough time. So it was revealed recently, and we did not so far manage to. Yes, we did not. The patient hasn't come, and we cannot register him. So this doesn't matter, because once the case is confirmed, it should be registered. And then it's another issue when the patient shows up for treatment or not. And I would like to add, so even if the case with the confirmed TB refuses treatment, we have to register, and then because this is TB burden, which means that we have a patient who lives in the region, and this is a confirmed case. So during 2 months, we try to attract this patient for treatment, but if we do not manage after 2 months, we registered that it was primarily terminated, even if the patient is not sick. But if this patient after a while starts treatment, it will be already a new case, even if this was the primarily thought. We also have problems with death registration. For example, somebody came from abroad to the inpatient clinic, and this person died. So we notify where the person is registered, but it is not registered here because they think that this will be a disadvantage for them. And by the end of the year, when I compare the patients, where the patients are sent, etc., how many, etc., nobody wants to take over the responsibility for that patient. So they do not want to report on that. Yes, also very good example. Everybody has had such cases, I'm sure. But we can see that in electronic database. Okay, thank you. Very good example. Okay. As to Moldova, I cannot remember the cases of over or underestimate or underreporting, but before coming here, Okay, so before we go to the site, we take name by name and not just numbers. On our own site, we get the lab data, we see the confirmations name by name, and the cases that are registered, we just compare them. So we have everything on hand, and if this is not revealed, yes, there can be also some human factor. Maybe they did not have enough time or something, but the laboratory, in any case, they register and we don't lose those cases and we can just follow up. Something like that. For how many years have you been doing monitoring? 6. Yes, okay. Thank you.
Thank you very much indeed. And there are different reasons in different countries, but we can see that it can happen in any country. So what should we do? All right. So now we look at the parameters of the data quality. We want, all of us, we want to have quality data. What should they be like? They should be accurate, reliable, precise. They should be comprehensive, complete, and timely. You would agree, right? And the question is then, what's the difficulty here? Because we ask for the reality, then why would anybody hide something or miss something out, etc.? So we want accurate data, right? So that we know exactly how many patients we have. And this data should be reliable. And so if I, miscalculated something, etc., it's better not to report, right? We want to have accurate and reliable data. And therefore, people who deal with it and who are educated about it, and if they know these parameters, it looks like there is nothing difficult to achieve, right? But at the same time, why are we here today? Because we want to do something better. We're missing something. Well, although I'm dealing with monitoring for about 20 years, there still is some sort of, dissatisfaction here or there and all the time. So would you agree? And would you say that everything's great in your country, or you need to improve something, right? Well, we are talking, and we will be talking actually about how to collect the quality data. So we want to improve, all of us. So if we teach people how they need to do all that, then of course we will have some good results. Well, in Georgia, it happened quite frequently that by the end of the year, everybody would want to know, to have the data, would it be the Ministry of Healthcare or any other agencies, to know, for instance, the total number of TB cases. So I'm asking you, can you give the figure on 2023 by the end of December, if the Ministry of Healthcare requires it from you? Would you give this data or not? Well, I can't, because we always explain that you want data, then you use this data, you analyze it, and draw some conclusions. But I'm telling you that the data may not be accurate and precise by the end of December, because we check the data. If you want some preliminary data, then we can give you the data for 9 months, because we collect this data on a quarterly basis. We shouldn't lie to ourselves or to anybody else, because the data is not checked and verified. Well, every country, of course, decides how to control data. We check the data for the first quarter after it's completed, after it's ended. So we start checking from April 1 until July 1, because the next monitoring will be done after the second quarter is over. So when people, no matter how high officials they are, if they request data for the whole year, we can't give them that. We can give them preliminary data, but the annual precise data, verified data, will be most probably available in March. Well, depending, of course, on the country. Nina was saying that we never give out verified data. So the system works for 20 years. And of course, every year we change something, we fine tune, improve, etc. And if we have very well trained data, then we don't ask of them anything but realistic. So when we started with the supervision, we had a case that 60 in one of the institutions, 60% were pulmonary, 40% non-pulmonary, and we said that, is something wrong with the data? Some of them may be increased, some of them, diminished, etc. And then it repeated again, and then we concluded that the head of the services, tell us what figures you want, and we'll give you those figures. So this is how it used to be, it seems, because this is what they were told, give us the figures that you want and we'll give you those figures. But we don't want anything, and we want realistic, the real figure. We want to know what the real situation is, so that we analyze it, so that we know what we're supposed to do. And then we'll have improvement on every step of monitoring. Do you agree? All righty then. Let's look and see whether it's difficult to do. Now, accuracy. We want accurate data so that they are valid, so that we can measure the data. And this lady from Ukraine, Olga, yes. I just wanted to say that during monitoring, yes, so trust and check anyhow. No matter how much we trust, we still need to check and verify the data. And we can't check it and verify it through Skype or telephone or whatever. And it will be different from when we take the field visits. And here we have to make all the steps possible to verify information to make sure they are accurate. And for that, we take the initial papers, we look at it, maybe there is an error, maybe mechanical, but still we can do that when we are at the agency, at this institution, a clinic or whatever it might be, and then we can compare. Otherwise, it will be difficult to identify the real reason for inaccurate data. Reliable, of course. If we want data to be reliable, then surely during monitoring, we need to have protocols. And they need to be ready too. And also, when you go to monitoring, do you notify these people always? No, we always inform them, because there may be so many mistakes that it's just a waste of time for us. But we're sitting and correcting because we want their cards, their x-rays, something is misplaced, etc. So we always tell them that we come and we need, all the data for the first quarter, all the x-rays, all the records, etc. Because if it's not confirmed to be, and the heaviest and the gravest cases, it's when we have not confirmed, and it is during clinical cases. So it's very good when they know in advance. And also, from my experience, they can't change anything. If you think that if you do not want them, we check the previous quarter. We do not check the number of of patients in April, on the 15th of April, if we check that, it doesn't give us anything because we want to know the cohort. We need something for comparison. So we take the first cohort, then we compare it with the same period of the last year, etc. All right, I couldn't hear what they said without the mic, I'm sorry. I just want you to remember this, so we need to really inform them and notify them that we're coming. We are here for almost 3 days. We listen to each other, and I want to make my narration quite practical. So I want you to listen to me and maybe compliment things if I skip or miss something so that you can add. Now, comprehensive data, complete data, we really need that because we either look at the regional data or the national data. If we analyze this in that region, then all institutions in that region, they need to report so that we have the exact, impression and of the region. And if it's the national monitoring, then everybody who deals with the TB, then they have to report. So this data shall be complete. No patient shall be missing, and all the forms that they have filled out, etc. So all of that must be complete. And only that would allow us for the proper analysis. If it's incomplete, then we receive a different result, right? It means that this analysis was basically wasted. It wouldn't give us any proper information for further decision making or whatever. Here is an example. In the region, they have 5 institutions. All 5 reported. We received complete data. We know that we have 1,082 cases, or it can be, it's just for an example. Somebody didn't report, so the data is missing, it's incomplete. And it makes no sense then to analyze this data. The analysis will be wrong, and we may go in the wrong direction as a result. It seems like the clicker is stuck. All right. 5 minutes. Important, crucial, I'd say, so that all participants of our program, they should know what is the meaning of the timeliness of the periods, and we have to inform them in advance and tell them that, for instance, provide us with the data and the reports for the first quarter, say in mid-April or end of April, something, and they need to send it in all together. It's like a clock, the monitoring program shall be like that. We need to know exactly, and they need to know exactly when they need to submit their report. And then the program decides these deadlines. Precise data, as I said, there are many details to it, and for instance, the data should be disaggregated. Sometimes they send us data that this is the number of pulmonary, this is the number of non-pulmonary, but we need disaggregated how many pulmonary, how many confirmed pulmonary, how many clinically confirmed, how many non-pulmonary confirmed and non-pulmonary non-confirmed, etc. Or the new relapses, how many cured, how many lost to follow-up or something. So when we request the disaggregation, then we need to have and to receive what's requested. So if they give us the data that they have 20 people and according to disaggregated, we have 22 people. Happens? Yes, it does. It is a mathematical mechanical problem rather. So we agree that yes, it's mechanical, but it requires correction. We need precise data, because if one institution makes 2 mistakes and then we multiply it by the number of total institutions, and it will be a completely different figure. So all facilities, all institutions, they need to control their own data so that whatever they submit in their reports is precise. And it's bad, if these figures do not coincide and if they are not right. Now, integrity, this is the data when it's generated by programs information system to protect it from manipulation, intentional or unintentional, doesn't matter, so that the data is truthful. Yeah. So the data is not really changed in any form or shape. 𝗿𝗲𝗀𝗿 said that when they went, that they were under pressure, the head of the service said that, okay, the report quickly, about what you have, etc., and just show that this is 100% data. If we don't show everything and we start explaining why it is there or why something is not there, then it will be, more talking and more mistakes. So it's better to always turn in all the data, because if it's not, complete again, we will not be able to have the proper analysis. So when you deliberately alter the TB evaluation rate to 100% to avoid queered about evaluation gap. As some may manipulate that, everything's great, there will be no questions or whatever. So we don't need to lie to ourselves. During the monitoring at every stage, I explained that here in this small town, you give us wrong data, then we receive this data, then we give it to higher instances, institutions, and this chain is wrong. And then it's interpreted wrongly, and therefore, every time we go to visit institutions, we've got to tell them that we need the quality data, otherwise it makes no sense to go. It's just a waste of time, waste of resources, waste of everything. I had a case when we visited some high mountains regions. Nobody visited them for a very long time. They've been accustomed to being far, visited, etc. It was in the mountain of Sahara. We, of course, informed them in advance, because it is quite far, we need transport, we need hotels, etc., etc. So we tell them that we come and we want to look at the labs, because we didn't like something that they indicated only 12 cases and expert was not there then, and a positive, etc. And actually, it's, like fresh air, there shouldn't be actually cases of TB. So we asked them to show us data just to compare, to take the logs like TB-04 and 03 and compare. And there was some sort of a bank holiday, and the lab technician with the whole family was attending that celebration, and we were sitting there and waiting. I mean, we were informed you, and we said, open the cupboard or whatever, and we went to open the lab, and it had a padlock, and they said what to do. I said, okay, break it. So we break it, the padlock, and the microscope was basically wrapped in the cellophane, and it was put on the top of the cupboard. Well, it's been a very long time ago. It's been when we've just started. And they just, again, they were accustomed that they are so far that nobody would ever come, nobody would ever look in, etc. So I asked, how come, you wrote that, there's 12 cases positive, but your microscope isn't wrapped. And they said, look at the x-rays and you will be sure that everything, it's really, they are positive. Well, we're surprised actually that they were sending data, but again, how can you find mistakes like this and deliberate manipulation of data unless you really go and see everything for yourself with your own eyes? And in my experience, the farther is the place, the worse is the situation. I would never imagine that in this, high mountainous regions that they would hide, they'll cheat, so to say. And when we do it regularly, because the monitoring is permanent, it's regular, it's continuous, it's not that you've looked at it once and then forget about it for 2 or 3 years. And every time we go, they say, oh, will you come for monitoring again? Yes, we will until we win the battle with the TB. It is a very important component to have quality data.
Давайте роли и обязанности. Сейчас пройдем роли и
обязанности. Let's go through the roles and responsibilities for maintaining data quality at each level of the healthcare system. This is a very interesting topic.
Какие уровни?
Now, what are the levels? So these are the facilities rendering the services, and then we have the intermediate level and the central level. I don't know, maybe in every country you have a different setup, but currently in Georgia we have this so-called rayon, this service delivery point somewhere in the smaller places, and then regional level and the national level. And sometimes we will go to villages where the patient resides. We look whether they have medication, whether they are treated correctly, and whether they, follow the treatment, etc. So we do it like in the capital city, because the best data is usually in the capital city. And if you go to, regions and districts, it looks like it's a different country. Now, at the intermediate level, we again review reports, we submit the aggregated reports, ensure timeliness and completeness of reporting, we monitor quality of data captured and reported, conduct routine supervisor visits, and routinely analyze and use data. At the central level, there is no big difference. We again provide guidelines on data collection, reporting, and management procedures. So, and the other control mechanisms are basically the same for every level. Well, without any explanation, I think we can understand what's this data. This is about verification of data at the central level, I think. So this is the central level, this is the regional level, and the district level, and the same probably same in your country. So we collect it locally first, and we collect it at the regional level, then we collect and compile and send it to the national level, so that we then analyze all that data.
Most common problems affecting data quality across system levels. So this can be technical problems, can be personal, behavioral, or organizational. Lack of guidelines to fill out data sources. Well, this problem exists because we haven't started supervision. If the supervision is already working, this has already been done, then we have guidelines. We know that without guidelines or explanation, nobody will be able to conduct monitoring. Shall we continue? Okay. This is a very good slide, and let's check. Let's see how are we supposed to assess the quality data. So before monitoring, during monitoring, when we are already on site, conducting monitoring, and after monitoring. So we have all the steps described very well here. These steps are necessary to maintain the quality. So before, we have to identify the team that will work about data quality. We have to identify region and facilities. So, and here I have a question. If you can okay, so the reporting of regions and facilities, are all the regions reporting? Okay, everybody in Armenia, all of them, and Ukraine, of course, I understand that it will be according to the situation. Well, develop approach and schedule. Of course, we have to know beforehand what are we checking, when and why, and how we're doing that. Okay, identify indicators. It is very important because people who are expecting you are going to check them, they should know what are we going to check so that they clearly know what are we trying to find, that because they have to have answers to all the questions. In that case, monitoring is good. Categorize the indicators, outcome-based. So pulmonary cases, non-pulmonary cases, for pulmonary, all the data we need. We have already warned about that, and if we have the protocol, then everything is described in the protocol. And we have to note here that protocols change all the time. Guidelines change, definitions change, treatment regimens change, and it should be immediately reflected in the protocols. For example, by the end of last year in December, we already updated our protocol because for preventive treatment, we hadn't added the outcomes of treatments, the regimens of treatments, but we already have to report for 2022. So 2023, we started with new protocols where this whole thing is very well defined and clarified so that the data are accurate. During the process, of course, we start with this introductory or entrance meeting, then verification of data, etc. So during the process of monitoring, we must be very respectful with our staff. Well, we have to talk about problems, what do they want, what are obstacles for them, why some mistakes are made, maybe they are having some obstacles. So it will be very good to start with that. If we find some issues, we discuss them together. Where do they come from? How they should be checked? How monitoring should be conducted so that all the indicators that we needed are checked, and all these inconveniences that were found locally were discussed immediately. So after monitoring visit, a detailed report should be developed. Everybody should be interested in that. Okay, so share report with facility and all stakeholders, follow up recommendations and action, so wherever necessary. So according to my so we are not standing at the same place. Everything is changing, everything is improving, and we conduct many trainings during monitoring. This is very important because this is support for our staff. In every country, there can be their own assessment indicators. So the country decide themselves what is necessary, what is important for them. So as a summary, we can say that indicators can be presence of trained staff, for example. They answer all the questions, everything is done well. This is important when we have trained staff. So presence of guidelines, all the TB specialists participating in this system, of course, they are trained and they all have their guidelines. They do everything according to the guidelines. Lack of tools or recording and reporting tools. So all the data, all the logs. So we have it centralized. We do it on central level, and then we distribute by regions. What happens in Moldova? Do you have forms, logs? Everything is everything centralized? Yes. So, and everybody fills out everything just the same way. Yes. It's the same in Ukraine. Yes, Bridget.
Oh.
I have no headphone.
Mhm.
Thanks, Marina. When you're going to the different places and doing these data quality checks, and you're
Sorry.
can you understand? Can you hear? You can hear? Okay. Marina,
Да,
when
я
you
сейчас слышу, да.
okay. When you do the data quality checks and you are using these indicators, for example, presence of guidelines, they might show you that they have guidelines. Do you also see if they understand the guidelines, or they are the most updated guidelines, or availability of data storage? I've been places where they have data storage, but when you look, they're still using like their phone, and they have things on their phone or their personal email, which is not the appropriate data storage system. So these are great indicators. Do you kind of dig deeper to see what is really going on, especially if they're expecting you to come?
Спасибо за вопрос.
Thank you
Конечно.
for the question. Of course, we take into consideration everything, and we're very strict with that. So how many times the guidelines are changed? How many are those new regimens or etc.? So thanks to Global Fund for having the opportunity to provide trainings for everybody. So when we give out the guidelines, it means that during 4 or 5 days, we provide them with trainings for those guidelines. We are the trainers. We discuss all the chapters in the guideline, but even though we go through everything, even if they don't read their guideline later, they have already heard about it. But one thing is to hear, another thing is to use it in practice. So when we visit sites and facilities, we start to check something. When the definitions are new at the beginning, we very carefully ask them questions. For example, the relapse definition has changed. It was different previously. Now it is the way it is. So we will check all the cases in the log. So let's do that. If we see the mistakes, for example, if it's a relapse and then it's not a confirmed laboratory confirmed case, so it means that this is a mistake, and the patient of interest has a relapse, the gene expert is negative, culture is negative. This is not a relapse. So we ask, why do they have this relapse indicated? Do you remember the definition or not? If they remember, of course, we just correct the mistake, but if they don't, then we observe the condition of their guidelines. So we ask them to find the relapse definition. So, and you can see that it was for the first time when they opened the guideline. You can see that. So these are skills of the supervisors that have been working for years on that. And we always say that it is much better to read first, in the first place, just to read, and only after that to record the definition. So we are on the move all the time. The new guideline, it means necessary training and then supervision. We also call supervisions as mini trainings because all the questions that have discrepancies, all the mistakes that we find, we always tell them that we are looking for the reason why this mistake was made. So it means that maybe you don't remember the definition, okay? Looked into the definition and the mistake was correct. Okay, so we do our best that during the supervision, they themselves can do it before our next visit. So if they have similar mistakes, so that next time, because yes, we leave them recommendations, what was revealed and what are the recommendations for improvement of those mistakes or errors. And after that, after every visit, we evaluate the facility. Good satisfactory, but so we always ask them how to evaluate them. We say that this is good, that is good, but this is not very good. We ask them whether they agree or not. They write down what they have to revise, what they have to improve. And then where we come back, we don't start like just in school, you know. We just make notes, we remember the mistakes from the previous time, and we start from those mistakes. If the mistakes have been corrected, it means that they're working on themselves. I cannot say that all the facilities do it like that. It's 50-50. Some people do that. Some people need to every time be told the same. Fourth time, fifth time, and maybe then something comes out of that. But we try, we teach them on site, and this leads us to some results. But if we don't provide them with training, so how do they know? That is our incorrect behavior. So we come to them and ask questions about something that we haven't taught them or trained them. So this is a cycle. So every after new guideline, we have training, etc. But recently we had so many updates and changes to the guideline. Previously it was some once in 5 or 6 years, but now we have every 2 years, and we are now expecting a new guideline. So once we receive a new guideline, we change the protocols. I told you that we have already changed the protocol because we are now reporting on the data of latent TB. But Nina said that the new guideline is expected in June. So with Maka, we have already discussed when to plan the training so that these definitions and these regimens and everything are discussed on site. And yeah, so that the support group, we call support group are the supervisors, and so then we on site work with them. And this vis-a-vis training is much more effective. Did I answer your question? Thank you. As we said, okay, in my protocol, the indicators of system and reporting is slightly different. You can also change them. You can look at the problems that you have and include those indicators so that these problems are solved. If these indicators do not help, then you can replace them with others. So, but this is on the discretion of the program and the manager of the program. I have a question. So you talk about indicators. So these indicators, for example, presence of strange staff, etc. So this is how you evaluate your general monitoring process, or by facilities. By facilities, this is when we, during the supervision, we visited a facility. Then we have almost, well, in smaller offices, we have 2 people, for example, the TB specialist and a nurse. And that is easy to judge. But this indicator have already been removed because we needed that at the beginning. Now it makes no sense to have this indicators because we train them all on the guidelines, and only after that they start using the new model on site. But how do you evaluate the monitoring team, the team that conducts monitor? I am the head of the central group monitoring group, and in Georgia we have 12 regions, so we've consolidated smaller regions. And in each region, I have a group working according to the program. So one of the groups is the coordinator of the region, supervisor of the region. Also, we have the support group. This is for example, it's a person working with patients who very poorly follow the treatment regime or don't come back for treatment, etc. So we requested this position so in 2008 when we had resistant cases, and it was 36 months treatment with injection drugs, etc. So, and we have also the base manager. So in each region, they are subordinated on the central level to our department. And if you want very exact description, I have it in slides. And after this presentation, I will discuss the Georgian version, and I will have these questions for everybody. And maybe it will be better that I describe how our group works. But the advantage is that in each region we have our group coordinator, the same chief doctor, observing the region. They conduct supervisions in every regional facility on the quarterly basis. Thank you for this explanation, how the monitoring is conducted from organizational point of view, but what are the indicators to evaluate the monitoring group? I'm not asking the levels and the composition of the groups, but how do you evaluate the quality of monitoring provided by the group? Do you have annual reporting on results or maybe some individual reports? As I said, these groups that conduct monitoring, they are our staff, regional staff, and we have on quarterly basis, they all come to the center. So apart from conducting monitoring and submitting protocols, we've been doing that for about 20 years. And we have representatives of Global Fund at the meeting because there are issues that we solve right there, and some of the issues should be solved by a Global Fund and the ministry. So these meetings, at these quarterly meetings, we discuss all the issues. And as to monitoring of the way they do their work, the central supervision is conducted twice a year, two times a year, yes, twice a year. So we look at the regions where our coordinators work, and the work they do there on site is checked from our side, from the center. And I was telling how do we check their work in the region. So our supervisions, according to the protocols, on regional level, are on regional level, and protocol on the district level are prepared by regional coordinators, and together with them, twice a year, we ask them which is the weakest facility, and we together go to that facility during one visit. We check 2 facilities and we observe with the protocol they fill out. And I can tell you that quite often these data do not coincide, and that is why they are all the time under the control. Also, we have a patient who in this region received treatment not in cities but in village. Here we visit without warning. So we come there, we watch the treatment provided, observe, we ask questions about the villages, then we go to the villages. Again, we visit two during every visit, at least two remote villages. Well, this is the primary level and what we check there. So we check how the OT is conducted, the treatment, because this primary network only helps us to reveal the cases when there are some complaints, etc. And they also help us geographically, because there are patients that for whom it is convenient to receive treatment there, and then the OT is conducted. And when my team arrives, the team consists of several people. So we check clinical part, reporting and recording, which is checked by me. We have also lab service, reference lab representative comes with us, and the drug management. And so when we go there, we are asked. So apart from counting the drugs, we ask how they provide treatment, how many times a patient comes, how many times they go for drugs, how many. So how do we check? We come there. So we have TB01, we have DOT. It's not a WHO form, it's such a form. So when the patient comes, they sign, and the chemist, they just count the drugs, how many were supplied, how many is still there. If there is some discrepancy, so if they have more, it means that the patient does not come. If they have less, maybe they were supplied less, etc. So coordinator are checked twice a year. That's what I want to say. And I told you we have 67 facilities. So how my central team manages to follow all the indicators during the year. So we stick to the time period. So just as soon as the first quarter is over, till the end of December, I have the authority to distribute all those checks. So there are closer facilities and some are remote. So if we go to Batumi, for example, we arrive, we don't work that day, we work next day in Batumi, but we work for 2 days in Batumi because we have many patients. And then together with the coordinator, we go to the 2 district facilities that are controlled by the coordinator. But we don't tell them that we are just okay, so they do their job and we just observe, and then later we tell them what was good, what was bad, and then we also go and visit villages. So this is done according to the schedule. The next monitoring starts in January and it lasts till 1st of July, because we check first and second quarter. So that is why I asked when if somebody by the end of the year asks a question. So what do we do? So we check all the cases. So I've told you, and we're doing this all together. We cannot provide data before end of March because the fourth quarter is finishes, and they have the right to observe those facilities during the next quarter. Then we all come together by the end of March, all of us, as I have already told you, and then our support group is there, thanks to Global Fund for that, because they support that, and we discuss those issues of the fourth quarter. So the monitoring results of the first quarter are discussed in June, etc. So it works very well. The system works very well, and I read and in some presentations and heard from some presentations that if everything goes well in the facility, it is possible not to visit that. We don't do that. It's just a law for us, you know. It's a rule. We go there every. So when they check a quarter, I check the whole year, and team. So we come up with the result that during 18 months we already know all the facilities we have checked. Well, it's not 1 year is not enough. So we need 18 months because in some regions we have 3 facilities, but somewhere we have 9. So if I every time check 2, then after 8 months, I already have an idea about all the facilities. I hope I answered you. We will go back to this topic, but there I will not repeat this whole thing. Key factors for ensuring data quality. We already talked about this, but we will just list once again because data element indicators, clearly defined roles and responsibilities of program staff at all levels should be clearly defined. This is very important to ensure quality and timeliness, and yes, to manage to do everything. So they already done something, we check it. If something was not done, we can start talking about that, but they are not looking for something somewhere, because I wanted to say about Moldova. So we tried both ways. Okay, and then we have this, oh, we did not expect you, we did not prepare this or that, etc. So the mistakes are anyway revealed. So that is why we ask them to get prepared, to show us the presumptive cases log, the contact log, a TB log, which is the Bible of TB in every facility, because everything can be said. The TB2 log, the forms that are individually compared there, and the histories of that quarter, because I think, yeah, because the most serious problems are to treat, problem is to treat non-TB, but we treat non-TB with clinical science, but the most, yes, and when we have clinical cases, they know that if this is a clinical case, all the X-rays so should be there, should be in place, because otherwise they will not be able to prove that this is a TB process in lungs and not pneumonia or anything else. Well, for me, it was very helpful that for 16 years I worked as a pulmonologist. I am, with my background, I am a pulmonologist, and I noticed that before us, people who were doing monitoring, they had only epidemiologists. They did not have clinicists and clinicians, and they were trying to prove me that it was TB, but I could prove that it was not TB. So, and I can say that we have very little. So everything, because yes, when I show them that X-ray shows that everything is okay, no calcination, nothing. It was really surprising when there was hyperdiagnostic, when, for example, yes, they said, well, these are minor forms and not, they might not be seen, etc. We've cleaned our data from any non-TB cases. We know that rifampicin is a wide spectrum drug. It's not anti-TB drug, but it has wider range. But when we trained our staff in the primary networks, that was before the resistant cases, we told them that we are very poor. We have very, we don't have much drugs. So it was 2006 when we lost some drugs. So we did not have the second line drugs. We treated patients by repeating the regimen, and then we just left it for the patient to decide whether they agreed or not. I could not say that everybody just rejected rifampicin, but we did not achieve the result of not selling this drug in the chemistry. So if we look at it by years, so there were different problems. Something was solved, something was not. We did not even talk about resistance, and before 2008, there were no drugs for that. But the most difficult periods in my monitoring work were the years when you remember we had very few drugs and no injections and nothing, and it was very difficult to organize. And if the structure is organized, if the system works in the country, if all the facilities are included, even when we selected a coordinator, there was a region where we could not select anybody, but we could not just leave this region without a coordinator. So we had to do it on central level before we found somebody, and after our visit we chose somebody who was trained, and after 6 months was already appointed coordinator there. So yes, we looked at the whole country. Nobody else knows where the problems are. Nobody knows better than us, and whatever audit is conducted, we know it the better of everybody. So on the commissions on the central level, it's very nice. All the problems can be solved, and the medications are in place. But when we ask about the regions, they say, oh, it's very far, it's a remote region, there is no TB specialist, we haven't been there. So this, we can say that whatever small the region is, it means that we do not have clear quality data of the country if we lack some data from even a small region. So we must make sure that all the facilities are checked in all the regions, and then we analyze. So you agree with me, yes? If we don't analyze the data, then these visits are just vain. This is where we were. We will finish it now. So we should know everything beforehand.
So people should not be surprised, and the data shall be precise, accurate, etc. And if we look at these parameters, and we see that it's sort of easy, and why do we have then so many mistakes? The most important thing is implementation. Even if the guidelines are issued, I mean, it's hard without training. So it's either they don't read, or if they read, they do not understand everything to the very end. And therefore, quality data is absolutely necessary, and this system should be working throughout the whole country. Would you agree? Good. So let's continue like this and improve our data. So when we create a plan, we should have the data review procedures, steps for addressing data quality challenges, storage policy, and filling practices that allow retrieval of documents for auditing purposes. And the best way to achieve data quality is to use then this data. And in conclusion, we agree that data should be accurate, complete, precise, timely, reliable, and the integrity of the data should be ensured. So if we can tick all of those, then it means the quality is good. But again, trust, but check and verify. So after this session, we come to a conclusion that the supervision is absolutely necessary. And our next session is exactly about the types of supervision, facilitating or supporting supervision. And then in the end, I will tell you about the 𝗍-𝗲𝗿 in Georgia. So thank you all for participation.